So welcome everyone to the Society of Thoracic Surgeons Adult Cardiac Surgery Database monthly webinar for September the 3rd, 2025. And I don't know about you guys, but I cannot believe it's already September. This year has flown by. So today on our webinar, we are going to have welcome and introductions, go over some important dates, some updates, and talk a little more about AQO. And then I'm going to turn it over to Melinda, who will share some new information on resuscitation and emergent salvage. On the call with me today from the STS, we have Leanne Jones, Emily Conrad, Banu Yatsi, Melinda Offer, and Paul Meehan. So welcome everyone, and thanks for joining today. So again, today, September 3rd, we will have our monthly webinar. Our next important date is September the 17th. We'll have our Adult Cardiac Surgery Database Quality Improvement Series webinar. That will be at 3 Eastern, 2 Central, and we will have a wonderful guest speaker joining us from Mary Washington Hospital in Virginia. His name is Mike Brown. He's a perfusionist, and he will be discussing strategies to prevent postoperative renal failure. So I'm really looking forward to that. Then September 25th through the 26th, we hope to see you in San Antonio for AQO. The next webinar will be October 1st. Then October the 15th, we will have our next quality improvement webinar. And then on November the 21st, Harvest 4 closes. So again, Harvest 4, November 11th, or no, sorry, November 21st, 2025 is the closure of Harvest 4 with an opt-out date of November the 25th. So just some information about our Data Manager Collaborative. The Data Manager Collaborative officially concluded on August the 21st. If you had submitted a request for a match by August the 20th, we'll make every effort to pair data managers. If you're already matched with someone, you are welcome to continue meeting with your peers. Moving forward, we encourage you to stay connected by attending our monthly webinars, joining a regional group, connecting through our Facebook group, and attending AQO. And STS just wants to extend its sincere thanks to all data managers who have participated in the various iterations of this program over the years. So AQO, we are so excited. I can't believe it's going to be in about 3.5 weeks. We'll be together in San Antonio. We are getting ready for you. And again, we're so excited. September 23rd, we will have our Intermax and PDMax session. That is a virtual forum. Congenital and general thoracic sessions will be in person in San Antonio on Thursday, September the 25th. And the adult cardiac sessions will be in person on Friday, September the 26th. We will be at the Grand Hyatt at the San Antonio Riverwalk, and you can still register for in-person or for the virtual options. And I just wanted to remind everyone that we will have a networking reception on Thursday, September the 25th. That'll start around 5 p.m. I know the Adult Cardiac Surgery Day is on Friday. The network reception is on Thursday. So if you're coming into San Antonio on Thursday, just make sure that you join us for that networking reception. We'll be so excited to see you there. Also, just wanted to remind you, this is our agenda for the adult cardiac surgery sessions. I know that we talked about this on our last webinar and it's available on the website, but I just wanted to point out again our breakout discussion groups. This is new for AQO 2025, and just wanted to point out that you should have received a link from the STS so that you could choose your top choices of breakout sessions to attend. We're going to be offering 6 of those. You'll be able to attend 3 of them. So we want to be sure that we get you registered into the sessions that you most want to participate in. So be sure if you haven't completed the registration for these on the link that you received in an email, that you do that as soon as possible. Melinda and I are busy working to get you scheduled into the sessions of your choice. So please respond to that as soon as possible.
And if you don't think that you received it, feel free to reach out to meetings@sts.org. And Elisa, the meetings and conventions manager, she's the one who's managing that link. She'll send it to you. So it's meetings@sts.org. And I just want to mention that this is for the breakout discussion groups are for in-person attendees only. So we're directing this to our in-person attendees at this time.
Thanks,
If
Emily.
I could just mention something, this is Melinda, only because I've been working on assignments this morning. It is really important that we get you assigned at a scheduled time into the session you would like to be into, because we don't want, 30 people at one session and 2 at the next session. So the plan is to make the assignments, and then when you register, you'll know what sessions you go to at what time. So that we don't have, like I said, a bunch of people in one group and nobody in the other group.
And
So.
your assignments will be on your badge. So on the back of your badge, there'll be a little label, and it'll probably say like table 1 to 6. And so you'll go in that order, and the tables will be labeled.
Very good. Thanks, Emily and Melinda. And I think that's probably all that I have for today. So I will turn this program over to Melinda so that she can provide some information and education for today.
I'm just having a glass of water because I've got kind of a meaty subject here. So the training manual for September has been sent to be posted, but I don't believe it's been posted yet. So what we're going to talk about today has to do with some training manual updates on resuscitation and emergent salvage. So hopefully Grace, I know, was out for the long weekend, so hopefully she will get that posted, if not later today, by tomorrow. We can go to the next slide. So I want to just start the conversation and say that leadership, we have been working on this project for quite some time. We want to update the intents of the resuscitation field and the emergent salvage field. Part of the reason we're doing this is because historically, when the database first started, resuscitation and emergent salvage, you basically were in a cardiac arrest situation. And as things evolved, we've added language where other things can be included in resuscitation or considered resuscitation. And now, with the advent of even newer devices, And the current use of so many devices, we, as a leadership and surgeon leadership, felt like we needed to clarify these two fields moving forward. So the first thing we're going to talk about is the current intent of resuscitation. So right now, currently, basically, you've had cardiac arrest within 24 hours of entering the OR, or you have devices that provide complete circulatory support. And we've not really laid those devices out much. We said ECMO, other mechanical assist devices like Impellas and LVADs. And we've also said that they needed to be initiated immediately prior to maintain life. So this is a life-saving device. And of course, we've had the language about the patient entering ECMO, who's going to have a cardiac procedure, that the additional risk of that patient is captured by coding salvage and resuscitation. So this is our current intent. In the next few slides, we're going to talk about our new intent of resuscitation. And like I said, this is in the September training manual update, which should be momentarily posted to the website within the next couple of days. Next slide. Okay, so resuscitation, new intent, indicate whether the patient required cardiopulmonary resuscitation within 24 hours of the start of the operative procedure. The start of the procedure begins with the induction of anesthesia. Capture resuscitation time frame within 1 hour of surgery, or 1 to 24 hours preoperatively. So we have two choices. Did the resuscitation occur with 1 hour of surgery, or is it 1 to 24 hours? So cardiopulmonary resuscitation has not changed. So it's not changed. The intent is still the same. We've not changed anything about that. The strike through in September 2025 has been deleted because we are going to clarify the devices that do provide complete circulatory support. So as you can see, the update for September 2025, resuscitation may include complete circulatory support, such as VA ECMO. So we're clarifying that only VA ECMO provides complete circulatory support. / other mechanical assist devices initiated emergently prior to entering the operating room to maintain life. Capture devices that are initiated that provide complete circulatory support to maintain life within 24 hours prior to entering the operating room. So we are clarifying that we will capture devices that provide complete circulatory support that are initiated within 24 hours prior to OR entry to maintain life. So the next slide. We're continuing with the new intent for resuscitation. Devices are described as complete circulatory support if the flow replaces the entire cardiac output. So that's pretty much equal or greater than 5 liters per minute. And partial circulatory support if the device flow only augments the heart. So we are looking for complete circulatory support. Examples of devices that provide complete circulatory support include, but are not limited to, VA ECMO, so it's only VA ECMO, tandem heart, Impella 5.5, long-term durable VADs such as a TAH, a HeartMate, or an HVAD, and heart assist. So we have clarified examples of devices most commonly used that provide complete circulatory support. In addition, we have identified devices that do not provide complete circulatory support. So intra-aortic balloon pumps, Impella CPs, Impella RPs, Impellas 2.5. They do not qualify as complete circulatory support. Those devices do not qualify. Next slide. And as you can see, as we've gone through this new intent, I've completely struck through the words about ECMO because we have clarified two things. We've clarified that only VA ECMO provides complete circulatory support. And we've also clarified that the VA ECMO must be initiated within 24 hours of surgery to maintain life to be captured. Next slide. Okay, so we're going to do a summary of resuscitation. So we have our current intent is in green, cardiopulmonary resuscitation within 24 hours, start of the operative procedure or as defined by induction of anesthesia. ECMO upon entering the OR, and then complete circulatory support. Now, the new intent, cardiopulmonary resuscitation within 24 hours of the start of the procedure has not changed. So that has not changed at all. We are clarifying that only VA ECMO provides complete circulatory support. We have also clarified that devices that provide complete circulatory support and are initiated within 24 hours prior to OR entry to maintain life are captured. And we have identified several of the most commonly used devices that provide complete circulatory support. And we've also identified devices that do not provide complete circulatory support. Okay, now let me see if we have a bunch of questions. I don't think we do, but somebody's got their hand raised. I don't know. Let's see if we should entertain that or not right now.
Yeah, let me, yeah. Okay, Dr. Ladonia, if you want to unmute yourself.
I'm sorry, I don't think I raised my hand.
Okay.
Oh, okay, thanks.
That's fine.
Yeah.
Okay, so I don't see any questions so far. That's good. Well, I see one. Let's see if I need to enter. Yeah, so Darlene has a question. So VA ECMO for greater than 24 hours pre-op will no longer be considered resuscitation. Yes, that is correct. It will no longer be considered resuscitation. It has to be initiated within 24 hours. Deborah, what if a patient is on VA ECMO for longer than 24 hours prior to OR and the patient remains stable? If it's longer than 24 hours, initiated with greater than 24 hours within OR, it's not resuscitation anymore. Okay, those are the only two questions. All right, now we're going to go to emergent salvage. And after we talk through emergent salvage, we are going to do some case scenarios. And hopefully by the end, you guys have a good grasp on this. All right, so emergent salvage. So this is our current intent. Okay, this is currently how we're doing it. The patient is undergoing CPR en route to the OR prior to anesthesia induction, or the patient has ongoing ECMO to maintain life. So those are our two current intents. Now we're going to talk about the new intent. Next slide. Okay, so as you can see, first thing I had to do is mark out the word I kind of marked out the whole intent just because we have updated quite a bit, and I wanted to make it look as clean as I could in the training manual. So, update September 2025. Emergent salvage. Patient has at least one of the following. The patient is undergoing CPR en route to the OR prior to anesthesia induction. En route to the OR includes the preparation time needed for transport and the active transport of the patient. So, I've got some examples of en route because I felt like we needed to define that or clarify that, what that means. So here's example number 1. The decision has been made to take the patient to the OR. The nurse is actively preparing the patient for transport, and anesthesia has arrived to transport the patient to the OR. The patient arrests after anesthesia arrives, requiring CPR prior to being transported to the OR. So that's en route. This nurse was actively getting this patient ready. Anesthesia was there to take him, and the patient arrested. That's considered en route. Another example of en route is while being transported to the OR, the patient arrests requiring CPR on the way to the OR. That's en route. Patient's actively en route to the OR. So again, the CPR en route has not changed, but we have clarified what en route means. Next slide. Okay. The new intent continued. Emergent salvage patient has at least one of the following. So number 2, the patient has ongoing resuscitation to maintain life. Ongoing resuscitation may include complete circulatory support, such as VA ECMO. So we've again clarified that only VA ECMO provides complete circulatory support. And other mechanical assist devices. So we have added language in here that other mechanical assist devices that provide complete circulatory support can now be captured. Initiated emergently prior to entering the operating room to maintain life. Capture devices that are initiated that provide complete circulatory support to maintain life within 24 hours prior to entering the operating room. So again, we have clarified that the devices that provide complete circulatory support and are initiated within 24 hours prior to OR entry to maintain life are captured. Next slide. Okay, so let's go over those devices again because this is basically the same language as resuscitation. We've tried to mesh them together. There's very few differences between them now, if not any, hardly. Okay, so devices are described as complete circulatory support if the flow replaces the entire cardiac output. So that is a flow of equal to or greater than 5 liters per minute. Examples of devices that provide complete circulatory support include, but are not limited to, VA ECMO, tandem heart, Impella 5.5, long-term durable VAD such as the TAH, the HeartMate, the HVAD, and the Heart Assist 5. So again, only VA ECMO is complete circulatory support. And we have clarified other devices that provide complete circulatory support that can be captured. We have also clarified devices that do not provide complete circulatory support and are not captured. So this is your examples of this are your intra-aortic balloon pump, your Impella CP, your Impella RP, your Impella 2.5. These do not qualify as complete circulatory support. Next slide. So again, the summary. Currently, it's CPR en route prior to anesthesia induction or it's ECMO. Now we have a new intent. So the CPR, again, has not changed. But the en route, we have clarified what that actually means. Examples that clarifies that only VA VA ECMO provides complete circulatory support. We've also included other devices that can provide complete circulatory support that can also be captured. We've also clarified that if you have those devices that provide complete circulatory support and they are initiated within 24 hours of OR entry to maintain life, we can capture them. And we've also identified devices that do not provide complete circulatory support, which will not be captured. Let's see if there's any questions before we move on to the scenarios. Erica. If a patient is in the cath lab and decompensates and is intubated and then goes into cardiac arrest en route, would this still count as emergent salvage even though, and well, Erica, I'm not sure that the anesthesia induction for the cardiac procedure had begun because the patient wasn't in the OR, if I'm understanding that question correctly. So yes, this would be a cardiac arrest en route because the patient was in the cath lab, decompensated, and then arrested on the way to the OR. Anesthesia induction for the OR procedure had not yet begun. Okay. Brian Nelson. So a patient on ECMO for 2 to 3 days will no longer be considered salvage. Yes, that is correct, Brian. And I'll give you a good example just to point this out. I had a question come in a couple of weeks ago, and it was about this patient on VA ECMO. And they were eating lunch the day before surgery, and they'd been on ECMO for like 10 days. So it, you know, that patient has been stabilized on ECMO. And even though that patient needs that ECMO to survive, that patient is stable. His kidneys are working good. You know, he's eating lunch. You know, his labs are in order. We're actually, the intent is really to capture people who are in the process of dying prior to in the OR. So these are unstable, not beefed up patients that you've stabilized and got their kidneys working good, their lungs working good, their labs in order, you know, so hence the change. Is the start of the procedure considered OR entry or skin start? It depends, Sharon. We can go back through some, that's why it's important that you read it carefully. So when, Nancy, can we go back to, let's just go back to resuscitation. So go back to, I want to see the definition exactly. Keep going. One more. Okay, so not that one, the new one. Thank you. So when you look at resuscitation, the CPR is prior to the induction of anesthesia, okay? But when you get down to the devices, it's prior to entering the OR room, okay? So it's sort of two different time frames in the same intent. So if you're coding and you're having CPR, it's prior to induction. But if you have a device placed, it's prior to entering. Now, emergent salvage, we'll look at that one more time and break it down. One more time. Okay. Go back to one more slide, Nancy. Okay, so when you look at the CPR for emergent salvage, it's it's en route. Okay, so this is en route and prior to anesthesia induction. Okay, so, and then if you look at the devices on the next slide, it's within 24 hours prior to entering the operating room. So I know it's a little crazy, but it needed to be defined that way per leadership. For surgeon leadership, it has to be defined that way. because we're kind of talking about two different things. We're talking about a cardiac arrest, but then we're also adding devices into, and so they each were defined slightly differently. So make sure you read the time frames. Okay. Let's see, Linda, if patient is in OR having a TAVR that fails to the point the surgeon has to replace the valve, how does that fit in discussion? Linda, we talked about that on the last webinar, but generally if the patient, it all depends. They're usually arresting. So if they're arresting and they're being resuscitated, then and it's an emergency procedure, then these rules would apply for them, like we discussed on the last webinar. We have special language about those types of patients. Heather says, thank you. Oh, thanks, Heather. Stacy says, does the same apply for transplants? If they have an HMIT3, it's not. Well, transplants honestly aren't really supposed to go into our database. So they have their own database. So I would say transplants, I believe we have specific language about transplants. So, and generally speaking, they're on these fads when they're at home coming in. So my general answer is no, it probably doesn't apply for transplants, just because they're optional to enter into our database in the first place. Nancy, do you have anything to add about transplants?
Yes, I was just going to say, if they're a transplant and they have their HeartMate 3, they're stable on their HeartMate 3 until they get their heart. So
yeah, I mean, unless it's initiated within 24 hours and they're very, very sick and they get their HeartMate within 24 hours of getting a transplant, which I think is highly unusual, but it could happen. So, but yeah. Okay. So is the stable VA ECMO patient greater than 24 hours considered urgent now then? Yeah. For the most part, probably urgent. Yes, Deborah. If the patient's stable and they've been sitting around for 5 or 6 days being stable, they're probably an urgent patient instead of an emergent patient. Does emergent salvage take them out of isolation? No. Emergent salvage does nothing to case isolation. It does play into your risk model, though, but it does nothing to case isolation. Take a few more and then we'll do our scenarios. If a patient has ECMO placed within 24 hours, then on way to OR codes, coding would in place within 24 hours, and then on way to OR codes would be yes to both, correct. Well, if the ECMO was placed within 24 hours, it's going to be both, period, if it's VA ECMO.
and she said VA ECMO.
Yeah. Or am I reading that question wrong, Nancy? Is there something I'm missing?
If a patient has, and she clarified VA ECMO. So if a patient has VA ECMO placed within 24 hours and then on the way to the OR codes, coding would be yes for emergent salvage and resuscitation.
Yes, that would be yes to both.
Yeah.
Okay. Stacy says, thank you. Let's see. We have had patients that are on dialysis and on ECMO or HeartMate and intubated, and we cannot code them as emergent salvage. Not if they are on ECMO for longer than 24 hours. No, not anymore. Or the HeartMate, same difference. I don't understand the whole question, but no, you clarified you always understand. Okay, thanks, Dee. All right, so let's do some wait a minute, let's see. Let's do the last one, then we're gonna do some scenarios. FYI, it's moving. I'm trying to read. Our Epic has a new upgrade which changes urgent and emergent classification to levels 1 through 5. Epic is not offering a crosswalk from the levels to our prior definitions. I can send screenshots. I'm not quite sure what you mean by that, unless your Epic has our definitions in there. I don't know what that means exactly, but you need to follow the definition and the intent that's in the training manual. So I'm not sure what Epic is offering. If you want to raise your hand and explain that to us, feel free to. Oh, Kim says Epic is used for OR scheduling, not STS. Okay, so maybe that's it. All right, so let's do some polling questions and see if I was able to clarify things for you. So, okay, so put your thinking caps on. Scenario number 1, patients admitted. Wait, I got to be able to read it. Patients admitted on 11/29 with syncope and a non-STEMI. On 12/1, he goes to the cath lab and they insert an Impella CP in for cardiogenic shock. And then they take him to the OR for a cabbage. So is this resuscitation? How is it coded? Yes, within 1 hour. Yes, more than 1 hour, but less than 24, or no for resuscitation. Whoa. Excellent.
Someone needs to sing the Jeopardy theme.
I think Paul, where is Paul? He signed up for that, didn't he?
Yeah, you don't want me singing. We have to change our alcohol policy if you want me to be singing.
Oh, okay. Wow, pretty good responses there. Okay.
Ready to end it?
That's it. I think it's just a fly-in answer, Nancy.
Yep.
Can you push the button?
Got it.
Thank you. So let's see what our answer is. Okay, the answer is no. And 83% of you said no, this is not resuscitation. And why is it not resuscitation? Well, first of all, the patient did not have a cardiac arrest. Okay, so we can just say no, we didn't have an arrest. Second of all, we had an Impella CP inserted. And we've clarified that Impella CPs do not provide complete circulatory support. I don't remember their exact flow rate, but I think it's something like 3.4 liters. And we are looking for devices that provide greater or equal to 5 liters per minute. All right, scenario number 2. Patient is admitted on 11/29 with syncope and non-STEMI. This is the same old guy. He goes to the heart cath. He's done 12/1. He gets shocky. They put an Impella CP in him, and then they take him from the cath lab to the OR. So how is status coded? Is this urgent, emergent, or emergent salvage? Well, I think it's pretty much slowed down. So the answer is...
One moment. I've got 3 things got going here. Okay. There.
All right, the answer is emergent. So why is it? And 71% said it was emergent. surprisingly, 28% said it was urgent. And we had very, I think it was 2% said it was a salvage. So why is this emergent? Well, first of all, this patient was emergently transferred from the cath lab for the cabbage. So they found something they didn't like in that cath lab, and they said, we cannot delay surgical intervention. So they took the patient right in, and that he was also in shock. So there was no delay. The patient was shocky, went right to the surgery. But it's not emergent salvage because this Impella CP does not provide complete circulatory support. So emergent seems to be the best answer in this scenario. Okay. Scenario number 3. Patient came in with a STEMI loaded with Plavix for cath. They found severe to subtotal disease in each coronary system, but they were unsuccessful with the balloon angioplasty and page surgery. While interventional and surgery were chatting, the patient slipped into cardiogenic shock and was emergently placed with an Impella RP and intubated and immediately moved to the OR. So how is resuscitation coded? Yes, within 1 hour. Yes, within 1 hour to 24 hours, or no. I could do da 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 da. You guys don't want to hear me sing, trust me. I tried karaoke, it never really worked for me. Oh, but Nancy sings pretty good.
Actually,
I've heard
no,
her
I
sing.
don't. No, I don't, but Sydney does, and Sydney is
Oh,
on the call today.
where's Sydney?
Funny thing, I forgot how to sing today.
Alrighty then. Ooh, this is kind of it's an interesting split.
Mhm.
Okay, it's a very interesting split. All right. I think we can shut it down here and see what the answer is. One memento. My little chihuahua has to be in here with me, and she was having a fit. Sorry. Okay, so the answer is no. Now, why is it not resuscitation? Well, 55% of you said it wasn't resuscitation. Yay. Okay. So first of all, there's no cardiac arrest. So the patient did not arrest. The patient slipped into shock, right? And then they intubated the patient, and then they put an Impella RP in. But the Impella RP does not provide complete circulatory support. So the patient was not arresting. The patient did not have a complete circulatory support device. So this is no for resuscitation. I mean, just because the patient was intubated, that doesn't necessarily mean he was in the midst of having CPR. They probably intubated him to protect his airway as he slipped into shock, and they knew he was moving to the OR. Okay, next scenario. Scenario 4, it's the same patient. So he's in the cath lab. He slips into cardiogenic shock. They put the Impella RP in, they intubate him, and they take him to the cabbage. So is this urgent, emergent, or emergent salvage? Oh, this is good. You guys
Yeah.
doing good with this one.
Mhm.
I think we could probably move on. I think I'll have 10 of these. Ooh. Okay, so 95% of you said that this was emergent, and that's the right answer. It's emergent. And so it's not emergent salvage. because the Impella RP does not provide complete circulatory split. So it's not salvage. And this patient definitely needed to go to the OR emergently. He slipped into shock. He got the Impella put in. He was intubated and went immediately to surgery. There was no delay. So this was an emergent surgery. Next scenario. Number 5. Okay, 7 o'clock in the morning. Oh, gosh, don't you just hate this? Change of shift. 7 o'clock in the morning, the STEMI patient went into VFib and requires defibrillation. There's just, man, your day's just started off really bad. Either that or it's ended really bad. Now, at 7:20, you take this patient to the cath lab, and they've got critical osteo-LAD disease. At 8:05, they put a balloon pump in. At 8:25, they take him to the OR. So is this resuscitation? Yes, within 1 hour. B, 1 hour to 24 hours, or C, no. This is an interesting split.
Mm-hmm.
Mm-hmm. Okay, looks like we stopped. So, 59% of you chose B, which that is the correct answer. So the correct answer is yes, this is resuscitation, more than 1 hour, but less than 24 hours. So why is this resuscitation? Well, the patient in the emergency room had ventricular fibrillation, required defibrillation. So he arrested in the ED at 7 in the morning. So he had a cardiac arrest. And then he was taken to surgery at 08:25 the same day. So he had a cardiac arrest within about an hour and 25 minutes of going into the OR. So that's why the answer is more than 1 hour, but less than 24 hours. So that's resuscitation. Okay, next scenario. Now this is the same patient. So he's arrested in the OR, in the ED. They take him to the cath lab. They put a balloon pump in, and at 8:25, he's taken emergently to the OR. So is this urgent, emergent, or emergent salvage? So he had a cardiac arrest at 7 in the morning, went to OR at 8:25. Oh, when he had the balloon pump put in. Good. Everybody's doing good with this one.
Mm-hmm.
All right, we could probably stop. It's pretty consistent. And 86% of you chose answer B, which is emergent, and that is the correct answer. So why is it emergent? Well, there was really no delay in taking this patient to surgery. He arrested, he went to cath lab, they put the balloon pump and went immediately to OR. So that's definitely emergent surgery. It's not emergent salvage though, because the cardiac arrest did not happen en route to the OR. The arrest happened an hour and 25 minutes ago in the emergency department. And then the balloon pump does not provide complete circulatory support. So it is an emergent surgery for those reasons. Next scenario. I think we've only got 3 or 4 more. This is number 7. So this patient was on 4:25. He came in for an inferior STEMI, or she came in. They did a PCI, and then they put VA ECMO placed for this patient for hemodynamic support. The CT surgeon says, I'm going to let this patient stabilize before it goes to surgery. So it must have been a pretty big inferior MI that this patient had. And on April the 28th, the patient is still on VA ECMO. Upon OR entry, the vital signs have stabilized, and the surgeon feels like they can have the surgery. So on the 28th, they take the patient to surgery. So is this how is resuscitation coded? Yes, within 1 hour. Yes, more than 1 hour, but less than 24, or no? Oh, people are fast answering this one.
Yeah, you did a good job, Melinda.
Well, the answer to this one certainly reflects that. I think we can stop. So 94% of you, this is great. You guys did great with this one, said the answer was C, which is no. And the answer is no, because this VA ECMO was initiated greater than 24 hours prior to the OR. This patient was stable. The surgeon allowed this patient to stabilize before they performed the CABG. So case number 8 is the same patient. We're going to go and do the same patient again. So you got your same patient, came in on the 25th, big old inferior MI, had the VA ECMO put in. On 4/28, the patient goes to the OR. ECMO's still in, but how are you coding? Urgent, emergent, or emergent salvage? Aha, I'm so happy. Y'all making me happy. Okay, I think we can end it. So 74% of you said that this is an urgent surgery, and you are right. This is an urgent surgery because this patient has been stabilized on VA ECMO for 3 days before the CABG. The vital signs were good. Definitely not emergent salvage. This patient had ECMO initiated greater than 24 hours prior to OR entry, and I would not call this an emergent patient either, because this patient was completely stabilized for, pretty stable. I mean, the surgeon said he's stabilized and I'm taking him to surgery. So there was no emergent need to take this patient. The surgeon let the patient stabilize and then took the patient when the patient was stable enough to go, which would be urgent in this case. Scenario number 9. Okay. Transferred for emergent type A aortic dissection repair. He presented with chest pain that began yesterday. His vital signs are stable. He's got no drips. He's immediately taken to the OR upon arrival from the outside hospital. So this guy's coming in from the outside. He arrested in OR after induction. How is resuscitation coded? Yes, within 1 hour. B, more than 1 hour, but less than 24 hours, or no. I like this split here, and I understand why I understand the split. So we'll talk about that. Okay, I think we can stop that one. 78% of you said the answer was C, which is no, this is not resuscitation, and that is the answer. And the reason is because this patient arrested after anesthesia induction. So remember, the cardiac arrest in the resuscitation field can't occur after induction. Okay, so it can occur up until induction, but not after induction. So, and as most of you know, there's always a risk anytime you induce somebody that they're going to just crash and arrest. So, and it's usually just from the induction agent. So this patient was not, this was not resuscitation because it occurred after anesthesia induction. Okay, next scenario, last one. It's the same patient, has this type A aortic dissection, and he gets transferred to your hospital. He's stable, he's no drips, but he's taken immediately to the OR when he gets here. And then he arrested in OR after induction. So is this urgent, emergent, or emergent salvage? Okay. All right. So 78% of you guys said the answer was B, and that is the correct answer. It's an emergent surgery. So let's talk about why it's not salvage and why it's not urgent. So this patient was emergently transferred from this outside hospital. I mean, even though he looked stable, he had a freaking dissection, okay? So, and they took him right to the OR as soon as he got there. So there was no delay. So it was definitely an emergent surgery. They didn't waste any time getting this guy to the OR. So it's not really urgent. It was definitely emergent. But it's not salvage because the arrest occurred after induction of anesthesia. So I think that's my last scenario. And I don't know if we have any more questions, but thank you for listening to me and putting up with me today. All right.
Thank you, Melinda. That was amazing. You got some very positive feedback on your great education. Appreciate your slides. Jo says she got better with each question.
Right.
Mary loved the scenarios. We do have a couple of questions on when these new definitions start.
September.
So
Soon.
September 1st.
Yeah, they're September. We just I don't know that Grace has posted it yet, but it's sent to be posted. I sent it over on last Thursday. So these are September updates.
Okay.
So September the 1st, September cases.
And then there was Dee says, thanks, Melinda. Great job. Heather, love the Q&A. Great quiz. There are some other questions up here. Katie, will you ever consider taking into account those patients that decompensate on induction?
Probably not, because something else caused them to decompensate, not their cardiac condition, but something that was done to them. Probably not. I don't think so. You, Nancy?
Yeah, I agree. Induction a lot of times causes patients to
Arrest. Yeah.
arrest.
Mm,
All right, let's
see.
see. So, Darlene, urgent versus emergent. The training manual includes language that says not responsive to any form of therapy except cardiac surgery. What scenario would this apply to?
Well, I think the one we just talked about, the aortic dissection. I mean, you can't let an aortic dissection, if it's an acute dissection, acutely. I mean, it's different if it's chronic, but if it's an acute dissection, you can't just let that set and not take care of it. That's one example. I think that some of the other examples we had in some of the scenarios where the patient is decompensating significantly in the cath lab, and because they have serious anatomy issues that need taken care of, that's another example. Nancy, can you think of any? Just I I mean, sometimes, you
That's-
get these
Yeah.
mitral valves that come in with ruptured papillary muscles,
Mhm.
acute rupture, and those you just can't hardly sit on them either most of the time. Just depends.
Yeah, those are good examples, Melinda. Let's see. Lots of thank yous from Janet. Sue also got better with each one. Ebony, great information, learned a lot. Thank you. Great answers. Great to answer scenarios. Great presentation and scenarios. Love the Q&A. Great topic. Yes, this presentation will be able to view again. We'll get it posted up to the website as soon as it's available. Should ECMO be coded in 810 as previous other cardiac intervention to capture the acuity of this patient, or will the MCS device section capture that?
You capture it in both places because if you look at the time frame in 810, it's prior to the procedure, and then you'd also capture it in the MCS section as pre-op. Yes. Grace wants to see number 1 again, scenario.
Oops. Leave that.
All right, number 1, let me read it. Is this the one you wanted, Grace? So let's see, resuscitation. This patient's 11:29, syncope, non-STEMI, goes to the cath lab on 12:1, slips into shock, puts in the Impella, and taken immediately from the cath lab to the OR. So resuscitation is no, because the Impella chest CP, I always want to call it chest pain, but it's not. It's not an Impella chest pain. The Impella CP does not provide complete circulatory support, and this patient didn't arrest. And then it's also not emergent salvage for the same reason. This patient did not arrest, and this patient had an Impella CP inserted, so that's not complete circulatory support. For the virtual group, there's a large break, 1:25 to 4 p.m. Nothing for us. So Michelle, I'm not sure that you understand the virtual option. You want to go over, and Emily's not
Yeah,
here. So
Emily had to drop off. So the virtual, for adult cardiac surgery, the virtual forum is on demand. So the agenda that we pulled up on the slide, that is for in person. So whenever the virtual content for the in-person sessions is available, those breakout sessions are not recorded. You will have access to the other recorded presentations on the live day, but not until I think it's a few weeks after AQO.
yeah, it's not like virtual when we were like doing COVID, like virtual live. It's not like that, Michelle. It's like these are recorded sessions, and you'll get that later.
You'll get the San Antonio sessions as a recorded version, and then you'll have access to the on-demand sessions, which you can view anytime.
Great.
So Justin's asking about, will there be time to discuss endorse measures and what some facilities are doing as PI to optimize them? We can certainly talk about that on future webinar. Justin, we can do that. Have to remember that, Melinda.
Yeah, I'm trying to, I know I get questions about that a lot. I know people are working on projects out there, Justin. It might be, are you on the Google group, Justin? Because if you're not, maybe you want to get on the Google group, because I know that I see stuff like that on the Google group. And it might be on Facebook too. I don't know, Nancy. Is there any discussion of anything like
There
that?
are some really good discussions on Facebook around that, around quality and PI projects. So that's another good place to get information for sure. Yeah, Justin, join our Facebook group. And Melinda, do you have any information about the Google group? Because Kara's asking about it too.
I think Kimberly Merlingo, you can send it to me. I think it's Kim though, does that. Is Kim on the call? I don't know. I know the email to get into there. Yeah, I could get you in there.
Okay, yeah. If you just have questions about the Google group, just let Melinda know. And then Michelle, I realize not everyone is on Facebook, but that's just an extra resource that we have right now. In addition to regional groups and this Google group. So if you can't join on Facebook, perhaps you can join the Google group. Or
Yeah, Michelle, don't feel bad. I'm not on Facebook.
Melinda won't join us on there either.
So cool.
Let's see. Patient has been on VA ECMO for greater than 24 hours, but notes indicated patient is unable to be weaned. This is coded no to resuscitation.
It is now. Yep.
Yeah. All right. I'm just trying to pull out some of these. Crystal's asking, has anyone taken over the Florida regional group for PAT?
Not
I'm
that
not
I've heard of.
sure.
I haven't heard it, but
Aaron, the Facebook group name is STS Data Managers.
you got that link somewhere, don't you, on this slide?
I do. You can copy this link. It's at the beginning. There is a link. You can copy that link and it will and put it in your browser and then you can pull it up. STS Data Managers.
Yeah, I want to address Darlene. Darlene, she says thanks. So if the patient is relatively stable, would be considered urgent rather than emergent, even if only treat. You know, don't get hung up on even if only treatable by surgery. Okay. I think you're wasting too much time on those words. So look at the patient. If the patient's sitting in the hospital for 3 or 4 days, still needs the surgery, right? But he's stable, and so that's an urgent surgery. If the patient is emergent, that's a patient that the surgery cannot be delayed for some reason. This patient is sick enough that they need no delay to get to the surgery. So, because they still need the surgery, okay? So don't get too hung up on even if only treatable by surgery, those words. I hope that helps.
All right. We did it. Only 11 minutes over. And just one more comment. Can we request, this was a great learning session. Can we request a webinar focused on STS risk-adjusted mortality, best practices on documentation and abstraction that can positively impact STS risk-adjusted mortality scores for isolated cabbage?
Yeah, I've done that before.
Yeah, I think it was one of our data manager, new data manager sessions on that.
It was number, I think it's number 2.
Yeah.
I think it's number 2.
On the STS website where you find the past webinars, we have a very helpful table now. Those webinars are pretty easy to find now. They've been organized. But it's new data manager session number 2, where we talked about risk-adjusted mortality.
Yeah, it's towards the end. I mean, I talked about 3 things and all the risk-adjusted stuff. And I made these great slides like that show you all the fields that are in especially the mortality ones that you really need to focus with documentation. So if you can't find that, Miko, just shoot me an email and I'll help you with that.
All right. Thank you, Melinda, for your excellent education today.
You're welcome. It's like we
Everyone
have some raised
really
hands.
appreciated it, and everyone was so good at the pop quiz at the end.
Yeah, you guys did great.
Yep. Miko says you're wonderful.
She's so pretty wonderful too.
All right. Well, I guess we'll end it here since we are over by 13 minutes. So thanks everyone for joining. We'll see you on our quality improvement webinar on the 17th. We have a guest speaker. So look forward to that. And we look forward to seeing you at AQO.
Mm-hmm. Yeah,
All
make
right.
sure you guys come up and talk to us, right? Because you guys kind of know what we look like, but we don't know what you look like. So please come up, and not a lot of you. So please come up and talk to us because I would love to like put a name with a face, right?
Yeah, we all would. All right, everybody. Thank you. Thanks for joining.
Bye.
Thank you all.
Bye.
Nancy, Melinda.